there. Oh, well, Asher, all right, Asher, you can sit there. You don't want him. I'll sit up with Stephanie.
Sure.
I'd like to welcome people. If we can have everybody's attention. I'm really very honored to be able to welcome Senator Paul Wellstone to the Kennedy School. Before I start, I'd like to talk a little bit about the format. Senator Wellstone will speak, and then what we're going to do is ask people when he's finished to move to the sides and line up to ask questions. And we'll stop the questions at about 3:45, which will allow Senator Wellstone enough time to get over to the medical school. So there's plenty of room for people to get out at that point. On behalf of the Forum at the Kennedy School and the Wiener Center for Social Policy, we're really thrilled to have Senator Wellstone here. I know he's met with many of his constituents already. There are a lot of Minnesota people at the Kennedy School, including many who worked in his campaign. And among our alumni, we number at least one person, John Pratt, who provided him with a tie before going to the caucus meetings when he first ran for office as state auditor. Is that correct? I talked to John just this morning. So we go way back in Paul Wellstone's history. We've got you covered. Before running for the Senate, Senator Wellstone was a political science professor for 20 years at Carleton College in Northfield, Minnesota. He is originally from Washington, D.C., and we have learned from Pete Zimmerman, who's on our faculty and followed you by I guess was 2 years behind you at, was it York High School? He said you were a great wrestler. And he wanted to come by and see if you were still wrestling. We've done it all. We've done all our homework. He then did graduate work at the University of North Carolina and went on to Minnesota. So despite his East Coast roots, Senator Wellstone is really a part of the Minnesota progressive populist tradition that for more than a century has characterized local politics and has brought the country people like Hubert Humphrey, Walter Mondale, and Eugene McCarthy. I'm originally from Minnesota, as are many of you, and people are often asking me, how is it that Minnesota continues to send politicians of this nature to the nation's capital? This is a very old tradition, and it's really hard to explain, but I wanted to tell you a few things about this, give you a couple hints. And one of the ways to start is to talk about Northfield, Minnesota, which is the town where Senator Wellstone lives. Northfield is a town, I guess it's about 12,000 people now, probably close to that. I think of Northfield as being the closest large town to Nerstrand Woods, Minnesota. Now, most of you have probably never heard of Nerstrand Woods, but Nerstrand Woods is the home of Thorsten Veblen. And if you've read The Theory of the Leisure Class, and if you know your Veblen, you have a good understanding of Minnesota politics. My father-in-law once explained this to me. He was the mayor of Northfield for many years. He said, you have to understand what it takes to remain in office in Northfield. You have to pay attention to the sign right outside of town. Now, Northfield is a town of 12,000 people with two well-known colleges, Carleton and St. Olaf. It has a sign as you drive in on the highway that says, "Welcome to Northfield, home of cows, colleges, and contentment." My father-in-law said, the world may know about Carleton and St. Olaf, but they don't vote. It's the farmers who vote. And unless I win that cow milking contest every year, which is part of the tradition of campaigning in Northfield, I'll never get elected mayor. And it's staying close to the roots of the original immigrants and their descendants in Minnesota who brought this populist progressive tradition over that explains the politics. Paul Wellstone made it to the Senate by staying close to these roots. He was the originator of the bus tour. Those of you who followed the campaign know that his bus wasn't quite like the bus we've been hearing about lately. It was a school bus with a platform welded onto it, painted green and white, that rode around the state, became quite well known, but took you everywhere, as near as I can tell, throughout the state, and reminded people of what the issues were that he was reaching out to everyone. Senator Wellstone is now at the Senate. He's a member of the Human Resources and Labor Committee, the Energy and Natural Resources Committee, the Small Business Committee, and the Select Committee on Indian Affairs. He's done a lot of work on rural issues, on health issues, and what he's here to talk to us about today is health policy in the future for the United States, and presumably your bill that you're introducing, right? Thank you, Senator.
Thank you. Thank you, Julie. You know, this reminds me, and I promise to get serious in a moment. I was looking to make sure there wasn't one of those risers, you know, that raises you up. The first debate we had in that Senate race, I was running against Senator Boschwitz, who is a giant. By my standard, that means he was 6 feet tall. And we went into the studio, and there was a technical person there, and he said to me, this was going to be a TV debate, he said, would you like he was very diplomatic, would you like a riser? Because then, you know, you'd be like the same height. And I said, no, if I'm going to win this race, I'm going to, you know, win it on my own terms, which is 5.5. However, I was also thinking about David versus Goliath. You know, sometimes it doesn't hurt, right? If you think about that. I mean, that's basically what the story was. By the way, on technical, a very quick hello. I got a button of the Harvard Union of Clerical and Technical Workers. I really appreciate the union, and I think organizing service and clerical workers is always very, very going to be really key to justice in our country. Let me, first of all, start out with a reminder that I have to make to myself to keep within a time framework. Julie had mentioned Hubert Humphrey. I came to the Senate. I was pleased to be there. I still am. I entered into a debate pretty quickly, did my very best, used to be a teacher, proud of being able to speak or trying to do my very best, finished up in the debate, felt good. This older senator, whose name I won't use, came up to me and he said, you remind me of Hubert Humphrey, and I was sky high, and then he looked at me and said, you talk too much. So I'll try and remember that as we go forward. I do want to thank, though, Julie and David Elwood and Joe Newhouse and Joan. Where's Joan Curran? Really, Joan is the major reason that we're here, and I really appreciate the invitation from the Kennedy School. Other point about Minnesota roots. My roots are not so Minnesota, and my father was from what used to be the Soviet Union, and my mother's family too, and my wife Sheila, who's here with me, is from Appalachia. You figure out that coalition, Southern Baptist Appalachia, Eastern Europe Jewry. Any case, in the mid-1980s, there was enormous economic pain in the countryside. And family farmers were being thrown off the land. And no one was presenting to or for or with the farmers any kind of compelling explanation about why they were losing their livelihoods and to them their lives, nor any empowering alternative courses of action. And that therefore became fertile ground for politics of hatred, racist, anti-Semitic, and all the rest. By the way, I think it's all too present in American society and American politics today. This is not to put the farmers down. I'm just simply saying that's what happens. So I was warned by some close friends, being Jewish, not to be speaking in western Minnesota, not to be out there organizing with farmers, which for many years I had been doing. But when you're 5.5, you never listen to that kind of advice. And some of you know what that means. So I went out to speak, finished speaking. Very big guy comes up to me, and he says, what nationality are you? And I thought, I don't believe this. And I said, I'm American. He said, where were you born? And I said, I was born in the United States of America. He said, where is your family from? Where's your parents from? I said, my father was from what used to be called the Soviet Union. My mother's family, too, although she was born in New York City and grew up in the Lower East Side. And he looked at me, he said, then you're a Jew. And I tensed up, and I said, I am. He stuck out his hand, and he said, well, buddy, I'm a Finn, and us minorities have got to struggle together. That's Minnesota at its very best. From that moment on, I knew I had a chance, even though I wasn't even thinking about running for office. I was at all. I was a teacher for 22 years, and consider myself a teacher now. And I used to say to students that politics is very existential. And every exam I ever gave, and they were almost always take-homes, I would require students to write on the following question. Maybe, no, did I have any classes? No, I don't think so. Why didn't you take any classes? We'll talk about that later on. And I would ask students to write on the following question. Why do you think about politics the way you think about politics? And I wanted students to think about what informed them. Family, religion, something crystallizing personal experience, parents, parent, you name it. I didn't grade it, but I wanted students to think hard about that. And that, I think, is pretty important for me as I think about health care. I come from a family, my father was an unsuccessful, though I think a very fine writer. I just don't think he was connected enough as an immigrant. My mother was a cafeteria worker, and medical illness in our family put us under for the better part of 2 decades. And I lived through that. And it makes a big experience. It makes a big impression on you. It's that simple. To bring this to enclosure, later on, when Sheila and I are in our early 30s, we moved my mother and father, both with Parkinson's disease, out to Minnesota. They were almost 50 when I was born. And again, we struggled with health care. Struggled to keep them at home. I wish there had been more home-based health care, more support for that. Struggled when they finally had to be in nursing homes. And to see, especially my father, over and over and over again, so preoccupied and so pained by the fact, this is very, if you will, Jewish, but I think it applies to all of us, that the savings that he and my mother had built up, albeit not that great a savings, should go to the grandchildren for college, but it was all going to be wiped out because of these nursing home expenses. Once again, just made me believe in the heart that there ought to be major change within this country and that we should move towards some system of universal health care coverage. Proposition number 1. You don't have to agree with me on any of these, but I want to kind of lay out my case. Proposition number 1, the health care system in this country is in fundamental crisis, and I'd spell that all in capital letters. If you agree with proposition number 1, then the proposition number 2 is we should not be talking about incremental public policy. We should be talking about fundamental change. Proposition number 3, that if we're going to be talking about the major challenges, public policy challenges, at least at the onset, I learned at lunch about some other challenges that I hadn't even thought about. One of those is the challenge of cost control, and another is the challenge of access. Proposition number 4. Proposition number 4, each and every citizen, in my not so humble opinion, deserves high quality, affordable, dignified, humane health care, regardless of income, employment status, and I could go on, but I want to also mention prior or current health care condition. Compare that to the realities, and I'm going to really skirt over the realities because I believe all of you here at the Kennedy School probably are familiar with them in one way or the other. So I won't give any of the statistics. I have them all committed to memory, and I think I could impress you with that, but I think you've probably heard it before. Let me just simply tell you what I hear as Senator from Minnesota, whether it be the Minnesota State Fair. And by the way, I'd like to make an argument for the Minnesota State Fair. It is very serious politics. Half the state's population comes in 13 days. Think about it for a moment. Each person counts as one and no more than one. Nobody comes with a lobbyist, and people come right up to you, and if they don't like what you're doing, and I wished I could tell you today that everybody loves everything I'm doing, it's just not true. They'll tell you what they don't like about what you're doing, and they'll tell you what they do like about what you're doing, and to a shocking extent, or to a shocking degree, or however I should say it, people will lay bare their personal lives, even if 100 people are right around them. And over and over and over again, Senator, I can't afford the doctor's bill. Senator, we come from a small town. We can't find a doctor. Senator, I have cancer and this bill is putting me under. Senator, I can't even get a job any longer because small business can't afford to hire me because I have diabetes, and it goes on and on and on and on and on. I mean, there are just too many people that aren't old enough for Medicare, and even if you were, it's not comprehensive. They're not poor enough for Medicaid, and even if you are, it's not comprehensive. And they're not well off enough to purchase private health insurance plans. And the interesting thing is that to a certain extent, I think, what we have seen in our country which had quite a bit to do with the electoral result in the presidential election, is not only low income or poor people struggling, but almost a submerged middle class. And it's surprising to me the number of people I meet my age, Sheila and I have 3 children in their 20s, whose children, having graduated from college, go out and obtain jobs that do not provide health care benefits so that they don't have any health care coverage. Those are the propositions, and those are the realities, and it's all those realities that I think make universal health care coverage or national health insurance of some kind a reality in the United States of America. That is to say, Roosevelt talked about it in 1935, so we're talking about a half a century later, and many people in here, teachers and students as well, know that many studies have been written, and many speeches have been given, and many reports have been written, and many policy recommendations have been made, followed by, roughly speaking, the same in action. But I think this now has emerged as a central issue in American politics because it cuts across such a broad cloth of the population. And there are new constituencies that have been galvanized and leading reform efforts, including professionals, providers themselves, much less important parts of the business community. So, what is the political landscape right now in Washington, D.C.? Let me try and not present a lecture, speech, or talk, or whatever you all want to call it, which is sort of just where I construct my own reality, as much as I would like to do that. Let me try and be as rigorous as possible and also tell you that I think, by and large, objectivity serves my subjectivity. The map. Single payer. That's the bill we introduced in the Senate. I'll make a case for it for the moment because I think it will be part of the debate, and I'll try and make a case for that in a moment. Single payer, from my point of view, represents the most desirable public policy and direction to go. The reason that I'm such a strong proponent of the single payer bill, which we've introduced in the Senate, is that I think a single payer has the administrative simplicity. I think it's the most comprehensive, and it enhances consumer choice. I will be direct, if not brutal, with you today because I don't want to talk down to anybody and no one wants me to talk down to them. And I will say to you that right now, I think it's unconscionable the extent to which the insurance companies write the rules of the game, compete to cover healthy people on the basis of risk selection, and it is unconscionable the extent to which insurance companies have turned the very insurance concept on its head to the point where you almost have to prove that you'll never use it in order to be able to obtain it. And the Supreme Court decision last week was chilling. H&H Music Company, self-insured companies can cancel out benefits, did that to victim of AIDS overnight, and Supreme Court turned down that appeal. Thus, I think, by the way, pointing to one of the problems of linking health insurance to employment, much less leaving it up to the insurance companies to decide the rules of the game. And I have also been, and some of you who are providers and some of you work directly in this field that know a lot more than I will be surprised that I was surprised. But I have been surprised the more I meet with doctors, nurses' aides, and others, the extent to which people in the healthcare profession themselves feel more than a little demoralized over the fact that they are simply not able to practice the kind of medicine they imagined they'd be able to practice when they went to medical school. And that all too often, they literally have to prescribe the kind of treatment that insurance companies will cover. That becomes the basis of what they can and cannot do as providers, not treatment on the basis of their best professional judgment about what ought to be done. I think single payer, one public authority, which deals with the financing, and that's all I'm talking about. I'm not talking about centralized, bureaucratized public policy, not government nursing homes, not government clinics, not government-run doctors, clinics, or all the rest, but I'm talking about a single payment scheme. Not only, I think, stands out from the point of view of administrative simplicity, but it also stands out because then there's consumer choice. And if people are interested in HMOs, fine, and if they're interested in fee-for-service, fine, and all of the rest as well. I also believe that a single-payer universal health care coverage plan is very strong because the package of benefits is tilted toward preventative health care, which the package of benefits should be. There is global budgeting, and there is also capital budgets that are kept separate, and a single public authority has the bargaining or leverage power to negotiate with providers. And I think there has to be accountability, structures of accountability built into health delivery in our country today. I don't think it's enough, as any conservative, good conservative would say, to throw money at the problems. I agree with that. I agree with that. All of that, I think, makes a single-payer universal health care coverage plan quite impressive, and if I was, and I won't, cite the General Accounting Office study or Congressional Budget Office study or other studies, I would argue that it's amazing the amount of money that can be saved just from administration that could be put back into delivery of health care. Now, I don't want to talk down to anybody here, and I think one of the big mistakes we've made, I mean no self-righteousness here, is that we have not been as straightforward to people in this country about the cost. With a single-payer universal health care coverage, there are two things that happen. Number one, you raise money differently, and number two, you spend money differently. If you don't have 1,500 different insurance companies, and you don't have a maze of rules and regulations and all the rest, and you don't have a maze of bureaucracy, then you will spend much less money on administration, and from the savings there, you will put it into coverage of services. Not just dealing with the uninsured, but the underinsured, and I think expanding services that are covered. Number two, you raise money differently. You raise fewer private dollars and you raise more public dollars. It is a fact that the bill we've introduced in the Senate is more expensive public dollars-wise, but for, I think, and I could cost this out for you if I had charts in front of me, but I would make the argument for the vast, vast majority of people, either you pay it out of your right pocket or your left pocket. If you pay it out of your left pocket right now, it's a premium. It's also out of pocket. And it's also tremendous anxiety about costs that won't be covered at all or being canceled out. If you pay it out of your right pocket, it's public dollars into a national health care trust fund just for universal health care coverage, but you pay no more with more comprehensive benefits with single payer, without that anxiety about what's going to happen to you or loved ones, and with a mechanism in place to control the rate of increase of health care costs over the years to come. That's the key point. I make no argument that single payer costs less money than other bills right now, but I think it's by far the most effective cost control. Otherwise, we'll be at 37% of GNP by the year 2020, and healthcare will bankrupt us. Next point. President-elect Clinton, has been critical of insurance companies in rhetoric, and by the way, I don't mean that snidely. I think political rhetoric counts, because political rhetoric is one way that we make promises. He has talked about universal health care coverage, national health insurance, in which case we have now crossed a philosophical divide in this country. That is to say, with President Bush and President Reagan and decade of the 80s, the operating premise by those two administrations was that when it comes to health care, there should be no major public sector involvement along the lines of national health insurance. That was their ideological position, and they had the First Amendment right to have that position. But it certainly meant that we weren't going to pass any kind of national health insurance bill in this country. I think now with the election of Bill Clinton, we move into a politics of rising expectations. I think people are expecting big changes. I think the economy, jobs is right there at the forefront, and I think health care is at the very top of the agenda. That's good news. What President-elect Clinton is talking about is not clear yet. I think Bill Clinton was, as a campaigner, we talked about this over lunch, deliberately vague, because it's pretty hard to campaign on health care, and quite often people who run for office are advised don't be too specific about the cost and how to finance it, because it's very difficult to explain, and in any case you're just too vulnerable to attack. But people want the change, and clearly George Bush stood for no change, and so Bill Clinton made the point, we're going to make a change, and there's going to be coverage for people, right? That's what we did here. At one time it was employer mandate, and now I think we've moved toward a system called managed competition. I'd like to talk a little bit about that, because I come from a state where we have done a lot with managed care. I'd like to talk a little bit about managed care and managed competition. To the extent that managed competition relies on managed care, and we are talking about hospitals and clinics getting together and sharing technology and prepaid group practice and a number of different people from a number of different specialties in the same physical location, all of that is for the better. And to the extent that group health, a health maintenance organization, and the Mayo Clinic can exchange notes and can exchange data on treatment, evaluating cost control, and all the rest, that is for the better. There is, I think, real promise with managed care as opposed to fee-for-service, prepaid group practice. Managed competition, as announced, I think, or as enunciated by President-elect Clinton, is something like this, as I understand it, and I think as you will understand it. Goes something like this. Every employer will have a sponsor that will search out for employers, or that for large employers especially, a plan, managed competition plan. Those plans will essentially get broken down to a cheaper plan, in which case your employer would pay almost all the costs for you as an employee. There will be another plan, too, which would be offered to you as an employee, which would be more expensive, in which case you'd have to pay more. I think there's a problem, because it's two-tier medicine. And I wish we wouldn't go in that direction. Be very direct with you. I hope we don't go in that direction. Then there's Medicaid and Medicare, and people who are without any health insurance at all, and they would be put into some kind of public plan, some kind of public insurance pool, and hopefully it would be the same package of benefits. They would have to pay some premium and some co-payments, and if the premiums are too high or the co-payment requirements are too high, then I think we will not have dealt with the problem of uninsured people in the United States of America. Because the fact of the matter is, if people are struggling to put bread on the table and they're not sick, they just may say, I'm not going to purchase a premium right now. And by the way, this is not a pathology of poor people. That is the way most of us are. If we have a very tight budget and we feel and we're healthy, we don't necessarily go out and purchase a health insurance plan. That's just the kind of decisions that people make. I think managed competition could mean a lot of bureaucracy. I'm not at all sure how it would apply to rural communities, which are very much oriented toward fee-for-service. And my biggest fear of all would be that there would be choice for insurance companies and for employers, but not for consumers, if essentially we divide up the delivery of health care just into managed care, competing against one another. And I would be concerned about that. And finally, I don't know what the role of the insurance companies will be. Many of them own a lot of the managed care right now, run those operations. And to what extent their imperative, which is commercial logic, which is, I can't fault insurance companies for that, that's what they're supposed to do, then impinges upon the logic of how we finance health care and deliver health care for citizens in this country. I worry about that to no end. I worry about that to no end. So, final point. I think that at this point in time, as we have this discussion here today, this is the right time. There's going to be a lot of jockeying. There's going to be a lot of bargaining. There's going to be a lot of policy work done. And for my own part, I think there's going to be some big steps forward. The question ultimately is what kind of national health insurance. If it's the next 100 days we're talking about, it won't happen. If you want to say to me, Paul, with the Clinton administration and you all as Democrats who control the House and the Senate, don't you feel under some pressure to govern well since you can't make excuses that it's divided government any longer? Absolutely yes. And do you feel some pressure to deliver for people and to pass some kind of national health insurance bill? Absolutely yes. I just want to make sure that it's not public policy which 10 years from now or less has been a dramatic failure, once again reinforcing the view of people that there are these terrible unintended consequences of public policy and public sector cannot be a force for good. That's what I would be most worried about. My own position. There's the insurance industry, they're huge. There's the pharmaceutical industry, they're huge. Common Cause did a study last 10 years, $60 million into races in the last 10 years, $2 million in the last year. They have enormous power. That's the power in Washington, D.C. In addition, I think, and they're opposed to the single payer. That wouldn't surprise anybody here. I mean, they are really opposed to single payer universal health care coverage plan. By the way, some very tough questions can be raised by such a plan. The fact that people are opposed doesn't necessarily assume bad faith. Pharmaceutical companies, they're opposed. That's point one. Point two, I think any national health insurance plan which relies more on public sector financing, albeit it have to be progressive taxation, runs into, I think, the difficulty of explaining that to people, that it's going to cost money. though less than we now pay as a country. But once you try and make the argument about the difference between private dollars and public dollars, that's not an easy argument to make in the public or political dialogue. But that doesn't mean we shouldn't do it. That's what I think leadership is all about. Third point is I think it all depends upon the grassroots. I read William Greider's book, Who Will Tell the People? I would recommend it for everybody here if you haven't. Who Will Tell the People? The Betrayal of Democracy in America. And I think he's right, that people don't have a way institutionally to connect themselves to politics, that many people feel ripped off and left out of the loop. I would tell you what my vision is about health care, and this is what we're trying to do. We are on the single-payer front working with a lot of people around the country, unions, consumer organizations, low, moderate income people organizations, senior organizations, some provider organizations, some of the best people right here in the Cambridge, Boston area. And essentially what we're aiming for is over the next several months, our vision is that every single representative and senator is going to be met by people for an accountability session back in his or her district in which people are going to turn up the heat. We don't win it fighting it out in Washington. But if, in fact, we go to the grassroots and we make sure the accountability sessions happen and people turn up the heat and make demands, as citizens should, for action, specific demands about the best kind of health care policy, then we go to the bargaining table. I don't think it'll be managed care as I spelled out. I hope not, because I think it's got some serious problems. But it could be a different kind of managed care. I don't know what the role of insurance companies would be. I'd like for the single-payer bill to be passed, but at the very minimum, conditions have to be passed which make it very difficult for insurance companies to continue with some of the abuses. There has to be a generous package of preventative health care benefits. Mental health has to be figured in. We have to figure out different ways of financing health care, medical education. We have to make sure that there's incentives for providers to deliver health care in underserved communities. All of that is a real exciting policy challenge. I'd rather be in Washington, D.C. right now than the last 2 years any day. I kept giving these speeches, enough speeches to deafen the gods in Minnesota, saying, don't tell me the differences don't make a difference between a Bill Clinton and a George Bush. And I would just simply argue that as I look to the next several years to come in the United States Senate, specifically to this 103rd session, I believe that we will pass some very, very important health care reform. Whether or not it meets the standard of desirability and goes as far as I think it should, will very much depend upon the extent to which the people in this country become a part of the loop, become a part of the debate, become a part of the discussion. So I find myself, on the one hand, working in the policy area. That's part of why I came here to speak with you all, to get your reactions and comments, knowing full well that there'll be a lot of negotiation to take place. On the other hand, working at the grassroots level. Last point. C. Wright Mills, I started out with C. Wright. C. Wright Mills had a wonderful phrase, at least to me. I talked about it when I was teaching all the time. He talked about the dangers of crackpot realism, quote, end of quote. And his point was, you should not let the particular public policy that you advocate, or how you think about yourself and your country and the world, or how you think about what you should be doing, you should not let that be defined by other people who have power as to what it is realistic to think, what it is realistic to do. I spoke to the new class of senators. We got some real interesting senators, you all. Real interesting senators coming in. And I said three things. I said, first of all, since I'm a 2-year veteran, right, and I know it all, didn't stop me from pretending to know it all. I said, first of all, stay focused. Lots going to be coming at you. Media's going to be coming at you. Leadership's going to be coming at you. Galas and big gatherings in the evenings are going to be coming at you. Remember your center of energy, and it came from the people that elected you, and try and remember what your mandate is. Second point I made, we have an interesting mandate. We're supposed to be outsiders, effective on the inside. And if that isn't a contradiction, that's one hell of a challenge. But you've got to keep that edge. And my third point was, beware of the dangers of crackpot realism, and remember the definition of realistic that the people who elected you had, not the definition of what it means to be effective and be realistic that is presented to you, or you all follow me, the minute you walk into the chamber of the United States Senate. I think health care is a perfect example of that. And I'm very determined to work with as broad a coalition as possible. I'm very determined to keep the pressure on for what I think is the most important and the most desirable public policy in this country. But I do not have such intellectual distance from the problems that people face in the healthcare area that I am unwilling to negotiate and unwilling to bargain and unwilling to be a part of enacting good public policy which will make a positive difference in the lives of people. That's why I think I came to the United States Senate. That's why I'm honored to be there. That's why it means a lot to me to be a part of this debate and this process, to really try and make a difference. I thank you. Okay.
Before we call on students, those of you who are familiar with Star Auditorium know that the acoustics are very poor. So if those of you in the back row can't hear the questions as they're asked, would you raise your hands, and then Paul Wellstone will repeat them. Right?
Yep. We'll go back and forth.
I agree with a single-payer system. One of many who support that proposal. Clearly, this is going to be a political fight. Yeah. And you talked about that, and you talked about the importance of organizing on a grassroots basis. I'd like you to speak to two aspects of the political fight for the healthcare reform. Please be more specific about the obstacles in the form of the fact that, in addition to what you mentioned, health PACs and individuals are giving more now than anybody else to Waxman, to Gebhardt, to many of the key players. Could you be a little specific about how that goes down, how that affects the debate? Yeah. Could you be specific about the members of the transition team in the Clinton group, who Judy Fader, I think is her name, and her assistant, and where you think their heads are at, what they're open to? Yeah. That's on one side. On the other side, I felt a little bit uneasy with the extent to which you were already, yes, compromise and bargaining is important, but it seemed to me that you were already, it sounded to me, the feeling I was getting, you were already giving up the game. And it's important, and it's going back to Bobby Kennedy, you go in there with this attitude of we're going to win this fight, and I didn't get a strong, this is for me personally, a strong enough sense from you that we're going to win single payer.
Well, we're going to mow them down. No retreat, no surrender. You know, actually, I'm telling you, first name? James. Actually, I did that, but it's a very, I'm going to learn a lot here, and it could be that that's an interesting point. I don't know how I'd love to throw that open for discussion almost, because let me take the first part of your question and then deal with the second part, which I think was a fair criticism, and he might be right. I'd love to know what some of the rest of you think, and apart from what your particular position almost is on the policy question, because it's a real, I'm feeling my way on this, and it's a delicate balancing act. First of all, on the money part, I won't give a personal analysis, okay? So-and-so is a sellout because I won't do that. I'll give an institutional analysis, and I'll tell you that at the top of the agenda for me, and I know I can't help it, I'm just at the moment energized, there's 3 areas we're going to lead the way. We are absolutely going to be in the middle of this policy debate if I have to just, and one of them is campaign reform, one of them is education, and one of them is campaign reform. And in fact, I think we got a great bill. And I think we're going to get a lot of good media coverage and be very visible in this. And I just think that I only wish that there was a grassroots constituency that was ready to fight for that the way I see it really on health care. And I don't think it's there. But I have to tell you that the way can I just briefly kind of say this? The way in which money has come to dominate politics in our country is the ethical issue of our time. We have moved so dangerously far away from the principle that each person should count as no more than one. It is frightening. We have a mini democracy at best, and the kind of corruption I speak of, you all, is far more serious than the wrongdoing of an individual office holder. I'm talking about systemic corruption that comes from a huge imbalance of power between those who have the financial wherewithal and can parlay that directly into access and political influence and political power, and those many, the vast, vast majority of people who are left out. Okay? And that applies to a lot of different areas, unfortunately. And you're right on the mark, and it's a huge problem for us. It's like the book that Michael Parenti once wrote. It ultimately comes down to a question of whether or not you have democracy for the few or democracy for the many. And we don't have democracy for the many. We have auction block democracy, government to the highest bidder. It's very frightening. I'm sorry, I think that's what we have. And I think it's wrong, profoundly wrong. And you know what? I think the vast majority of people in this country believe that. Okay. The second, but I haven't finished. The second part, I don't know what to say to James about. I know they're too long in answers. It's because I was a teacher. I blame it on the profession. You can't. The second part, I don't know. He could be Ellen Schaefer, who's with me. I think agrees with you. Who Ellen does all of our healthcare work, and she's, I think, been trying to, between the lines, say the same thing. See, what I've been trying to do when I spoke here today at the Kennedy School, I mean, this is the Kennedy School, you know? I mean that in a good way, not in a snide way. I'm proud. Do people ever put you down and say, I'd like to leave the Kennedy School and go to the real world and stuff like that? I don't believe that at all. I think ideas matter in politics. I think the intellectual environment of a country is incredibly important. And what I was trying to say is that, look, I'm going to fight really hard, but I'm not. But I understand full well that people in the country are saying you can't have gridlock forever, Paula. You're just going to say it's all that you want or nothing. Are you not going to be willing to negotiate and compromise and be a part of fashioning something that might not be all you want? And I guess that's what I'm trying to say. But if it comes off too much like you're already throwing in the towel before you really make the fight, I apologize for that, because I don't mean to come across that way, okay? And we're not going to. And those people who say, well, single payer is dead, everybody's spreading every kind of word everywhere they can right now for political advantage. I don't think that's the case.
Anything about the transition?
We've had some preliminary discussion, and I can't tell you much more. I think I'll know a lot. It's not at all clear what exactly the transition team or the administration has in mind yet, other than what I reported. And the latest really is this managed competition. I think that's the roast. I'm looking around the room where there are some real experts here. I think that's what we hear the most about. Yes?
I'll try to make this brief. In terms of healthcare politics, the most comparable example to today's situation is probably 1964.
Yeah.
And we all know the result of 1964 in terms of healthcare was Medicare and Medicaid enacted in 1965.
Right.
While that may have solved many of the problems perceived at the time, many people would say that's a prime cause of a lot of problems we feel now.
Right.
How confident are you that today's situation will yield some sort of compromise that endures in the long term?
Well, I think, first name?
Steve.
Steve, I'm going to, believe it or not, give a shorter answer, because there are lots of people standing. I think that's a very interesting, you know, we work with Ted Marmer, who wrote the book, The Politics of Medicare, and he's a very strong advocate of single payer, and I must say very eloquent and very effective. That's what I meant when I said I would worry about. See, you could take the Medicare, Medicaid example of 65, and you could make a couple of different kinds of arguments. You could say Medicare and Medicaid, the government got involved. The government got too involved in the private sector, and you had rampant inflation ever since, and now older people are paying more out of pocket than they did before, right? Thus the unintended consequences of social policy, thus the conservative case against social policy in the United States. You could make the different argument, which is that Medicaid, Medicare was an example of too much private sector involvement in the public sector, which was able to able to finally control the agenda as to the actual legislation that was passed and implemented, right? And therefore, indeed, it was. Here's the money, here's the blank check, you fill out the amount, correct? With no accountability built in. I'd be very, very worried that we will make that mistake again, and I don't want us to pass a major bill saying that this is the reform effort and leave large numbers of people, A, still without decent coverage, and B, not have an effective cost control and run into the same problem. And by the way, I do not believe that any of the other proposals, as compared to single payer, are at all convincing in terms of how you're going to affect between now and the year 2000, $700 or $800 or $900 billion of savings. I have not seen anybody be able to make that case. Yeah.
Let me first say that I feel passionately that we do have to have some kind of universal health care access, but I'm still trying to figure out, like most of us are, what the best system
Why
is.
passion? Why do you feel so strongly about it?
Well, any country that is to be a great country needs to have health care for all their citizens. My question to you is a concern that I have with your proposal, which is the fact that no one directly faces the cost of the health care, at least not the key players, the doctor and the patient. And as a consequence, there's overconsumption. I worked this summer in London with the National Health Service, and they're struggling with that now, and huge waiting lists, and sometimes not always the best care. So how is your plan going to take into account prioritizing or dealing with the constraint, the budget constraint that it'll have?
Well, there actually single payer is very. If you argue that the biggest part of the skyrocketing costs is overutilization driven, provider driven, then the single payer, a public authority negotiating with hospitals and clinics on capital budgets and global operating budgets annual, okay? And by the way, Bill Clinton has made a commitment to caps. In a sense, he's made a commitment to global budgeting, which I think is a healthy thing, personally. The question is, but then once you talk about how you're going to have a cap, do you all know what I mean? That you won't have health care costs go up any higher than X percentage increase in GNP, maybe plus an additional % or 2. That's fine as long as you can be clear about where you're going to, how you're going to meet that goal, right? That's what I get worried about. So I think we're pretty good on that. Where we're weaker, some would argue, let me be very straightforward, I am not a fan of, and maybe again, James, don't get angry at me, this might be a place of compromise. I have not been a big fan of coinsurance and deductible requirements because I argue that the cost has not been mainly consumer driven, and my argument is that the class that it has, if on the one hand you want to encourage preventative health care, I think on the low income end you do exactly the opposite with copayment and deductibles. But some people argue, Paul, that's a big mistake, because then what is the incentive for consumers not to overutilize? That's probably where we're weakest, depending on your point of view. Depends upon how you look at the evidence. Do you all see what I can't, the reason I keep looking around the room is some people I know have been very plugged into this debate for a long time, and others, if I'm you know, using acronyms or saying things like that too quickly, please let me know. It's like, have you ever heard of, do you know PUCA? Do you know what PUCA is? Well, clearly your education is deficient here at the Kennedy School. PUCA is the Public Utilities Conservation Holding Act. It took me a while to memorize that. I became one of the 5 leading experts in the United States of America on PUCA. That's true. I mean, there were none before the debate started on the Energy Committee. But, you know, wow, I get on this committee and people are talking about PUCA, and it took me, you know, I mean, when you're new, it takes you a while, you know, to finally, it's like raising your hand, like, what the hell are you talking about? Anyway, then after I found out what it stood for, I had to find out what it did. Then, go ahead.
In addition to access and costs, have you given any thought to whether or not the approximately investment in biomedical research can be leveraged in any greater way than it is now to assist care directly?
No, it should. How about, I'd be interested in a little bit of your thinking on this.
Not on the spot right now.
Well, if you can't answer the question, don't ask it. See, this is the way I used to teach. It really works well.
I asked if you...
I mean, it really works well. The other strategy, it's a great question,
and
and the answer is we have not thought through really the whole research component and how that ties into better delivery and better quality of health care. But it's on the list of questions that we have sent out to people for more reaction. Does that help?
Yes.
But you know, the other thing that worked for me in the class, that was a good one, but the best thing in class was when a student asked a question that was really difficult and you just didn't know how to answer it, but you knew you should be able to, the best thing to always say was, that is a very good question. It's an excellent question. We only have 20 minutes, and I want to do that question justice, so we'll put that off and devote the next class, and then you go read 20 books, and then you come back in and you say, no, but I'm not done. Then you say, you start out, it seems to me, no, I'm kidding. I'm kidding. When I was in graduate school, everybody talked that way. It seems to me. Everybody said that in seminar. It seems to me. And it may have seemed that way to each of the me's, but it was based on the books that we had just read. And I could never understand that.
Well, it seems to me that the
I'm Minnesota. Yeah, Minnesota.
one of the things that scares people about any talk about national health care, national health insurance, is they feel that their health care will be further removed from their control.
Yes.
And they're afraid that we'll have some monolithic bureaucratic organization that tells them what they can and cannot get. What do you intend to do? What do you see as being structures that work to localize those kinds of decisions and those kinds of controls in the context of universal insurance?
Well, Pat's point is, I mean, there's a couple of big, not Pat.
It's Dan.
Dan, I'm sorry. Dan's point is really important, and next class we'll deal with it. No, first of all, I think people in our country are very ambivalent at best about government sector involvement in any number of decisive areas of social life, healthcare included. That's number one, Dan. And I think that's part of the, if you will, obstacle to overcoming this debate. Number two, I think when people hear government, they think centralization and they think bureaucratization, and they have, in all too many cases, every right to be concerned about that. Number three is, and we were discussing this in lunch, we just kind of didn't really resolve this, but my view is that you want to decentralize public policy to the maximum extent possible. And for example, in single payer, you want to make sure, I mean, the provinces in Canada that's most closely modeled after the Canadian system, not identical, really have a lot of decision-making power. So your states would become your single payers, or your states could contract out to an insurance company to be single payer. And I would like more of the decisions made at that level with some clear federal. I think federal has to be on package of benefits. I think there has to be a national standard on package of benefits. The problem becomes, this is the age-old debate about federalism and about revenue, revenue sharing and all the rest. On the one hand, if you don't have a lot of federal rules and regulations, it's better and gives states more room to operate. I think that may happen. I mean, some people just want to have legislation to let some states go forward now. On the other hand, and in Minnesota, not to brag, but to brag, I think we are in a grassroots political culture, I think we lead the way in a lot of public policy. On the other hand, in other states where the balance of political power is a little different, and where some of the people who might be most hurt with the least amount of clout, the political verdict could be very harsh without some clear federal standards, rules, and regulations and requirements. And that, I think, is the dilemma. For my own part, I still think we ought to try and, with the single payer, give states a considerable amount of discretionary power in terms of how they work out their delivery of health care. Yeah.
Okay. Yeah, you made a lot of good arguments for a single-payer system.
Yeah.
But there are also a lot of arguments against it. And one, I guess, being a political scientist, is about political culture.
There are no good arguments I know of against it.
All right.
Now go ahead.
All right, let me try. But, I mean, there are people who argue that a single-payer system goes against the political culture of the United States, whereas it might not in Canada or Europe. Yeah. You know, number one is there's a strong public distrust of government in this country, which doesn't seem to be getting very much better. You know, term limits and the like show. And number two, if you look at the way we've addressed social problems in this country, even ones dealing with human needs like education, housing, food policy, we don't have the government taking over the whole industry or the financing. We've addressed public programs to deal with where the market fails and leave the market to function. Why is healthcare different, and do you think political culture applies?
Well, I don't think you allocate healthcare according to a strict market verdict the way you do haircuts or color TVs. I think it's too essential. Okay? It's too decisive an area of public life to treat that way. And I think right now we see the cruel effects of the way we do it. Number two, I don't think the bottom line can be the only line when it comes to delivery of health care to people. It's too much in the personal and national interest. Number three, I talked about financing. I did not talk about, again, government run, hospitals, clinics, and all the rest. And number four, and some of you all may want to correct me, those of you who have been looking at this a longer period of time than I have, I think not that we should sniff polls and that should be the #1 criteria of what we advocate for, but I think healthcare is one of those areas where, in fact, people have pretty consistently for a long time in this country say that they are in favor of some kind of national health insurance, and they do favor government involvement, government financing involvement in this area. In fact, I think the vast majority, I mean, you know, really, our system is the most expensive and the least popular. It's the most expensive and the least understandable and the least comprehensive, and doesn't do well in terms of popular support right now. So while I accept your point, and I think it's a good one, and I think we ought to have a strong private sector, and I think people have every reason to be wary of government involvement, I think this is one such area of decisive area of public life or social life where it's a different calculus, as is education. And by the way, I would like to make the argument that there are a good many government programs that have worked. Some haven't. Yeah.
Yeah, to get back to a point, looks like...
Is that okay? Yeah. I mean, okay?
Senator, it looks like I could use the platform you're not using here. I'm visual reaching the mic. To get back to something that was suggested earlier about sort of the consumer-driven increase in use of the system, what I'm really wondering about is things like self-imposed risks, moral hazards. Best example that comes to mind, don't mean to offend anyone who smokes, is smoking is something that you're doing to yourself that you know is really creating huge health problems that's going to cause enormous costs on the system later. Without co-insurance, I mean, there are plenty of other things you could think of, not eating properly, et cetera. Without co-insurance or co-pay, since you said you're not too crazy about those, how would you avoid such things?
Well, I think that's a very good question, and I don't, by the way, I don't think that probably, I think it's a bit of apples and oranges. I have a feeling that co-insurance, the problem with deductibles and co-pays is that it casts too broad a net, and it wouldn't be specific to just that problem, and I think you discourage people from using care, from coming in when they should really be receiving care. I don't know. Your first name is?
Lewis.
Lewis, I don't know quite how to answer that question. Again, to draw on a lunch discussion, in my own mind at least, I think there's a difference between the right to health care. This is where you and I might have common ground. I think there's a difference between the right to health care and the right to control your own health. And I would hate to see us pass, let's say, the best of all worlds, a really good, desirable, comprehensive, single-payer, universal health care coverage plan in the United States of America, so that we no longer ration. You all know how serious it is the way we ration health care now, right? I don't need to make that argument that the argument that we're going to ration with some kind of national health insurance plan pales into insignificance by the cruel rationing we do now. Let's say we made the major change. What I would be worried about would be that people would become clients. People would become dependent upon, I'll receive my care, and people would forget that they have a responsibility to take more control for their own health, so that they don't smoke, so that they exercise, so that they eat better, right? And all of the rest. Now, can I make another point? It's hard for people to take individual responsibility unless they have some power. And the problem with the argument I've just made is it's a good argument if it's an empowerment argument, and it's a bad argument if it's a blaming the victim argument. And I've met a hell of a lot of people right there in Rice County where I lived, right not too far from Northfield. I could lecture them day in and day out about how where they were working was unsafe, and they would tell me the choice is between putting bread on the table or not. And they laugh if I talk about cigarette smoking, given the kind of what they were breathing in at the factory they were working in. So we get into a whole environmental agenda where maybe, you know, all of us ought to have just a little bit more power in terms of affecting what we eat, what we breathe, and what the quality of the water we drink. So this becomes a broader definition of health. Yes.
Senator, I'm interested in the trade-offs between increasing access and defining the scope of the coverage you can fund and priority setting in health care. I mean, as you know, the different states that have acted or tried to act have each taken a different cut on this. Minnesota, Oregon with its proposal, Hawaii, et cetera. And I was curious to know what you glean are the lessons of these different state experimentations in terms of the priority setting exercise, and whether you can give some feel for the substantive, as opposed to the procedural criteria, you would favor in setting those priorities.
If you could tell me what you mean by substantive as opposed to procedural, then I can probably answer the question.
Well, if you look at the scholarly literature, you see Dan Callahan proposing one set of substantive criteria, Norm Daniels proposing another. The route that Oregon purported to go was largely procedural, but no one really believed that when they looked at the final analysis.
Right.
Substantively, it didn't make any sense. The dentures were so low on the list, et cetera. So it seems that we're struggling with very little consensus about what substantive criteria to embrace. How do you rank different healthcare interventions when push comes to shove and you have to decide what to fully fund, what to partly fund, what maybe not to fund for right now?
Right. Well, a very fair question. Let me answer it by just telling you first name, if I
Susan.
Susan, that I think there is a strong consensus. I can't speak for the Clinton administration at the moment, but in the Senate deliberations, of which I was a part among the, if you will, healthcare whips, we put an extremely, I couldn't even, I should have come with a list of the kind of package of benefits, but we tilted it very, very heavily toward the preventative health care. That was like, that's what we could, that's one of the major things that we agreed upon. We really, that's my first point. And I mean, that's really in a way my answer, but let me give an example too, above and beyond the obvious one of, you know, let's make sure that prenatal care and postnatal care and childhood immunization is all. I pushed very, very hard because of experience with my own parents, and I feel very strongly about this, that there should be, and this is something, by the way, that people are having a tough time dealing with in healthcare, which is long-term care, because it's very expensive, and mental health, which is the other thing that's been left out, I think, in all too many plans. We put a very strong emphasis on long-term care, on home-based health care. Now, that's a substantive decision that there's 2 points to be made. I think that people should, I think the goal of healthcare policy and what you cover and what you don't cover is to enable people to live in as near a normal circumstances as possible. Number one, it's the right thing to do. Number two, it's the most cost-effective thing to do. That's where we have consensus, and that's where I put my emphasis. I would put my emphasis on that long before I would rationing, the kinds of decisions that, you know, people in Oregon are saying you have to make.
Forced to cut out, though, where do you cut? Organ transplants?
Well, wait a minute. I mean, forced to cut, with the cuts that you make, well, okay, that's an easy question for me to answer. See, I don't accept those trade-offs at the moment. See, I don't think we have even begun to cut in the administrative part, insurance company overhead part, and we should. I don't think we have even begun to realize savings that we could realize from preventative health care, family practice, backed up by specialization, and we should. I don't think we built any structures of accountability into this healthcare system to deal with overutilization of technology, overutilization of prescription drugs, overutilization of surgery, and all the rest, and we should. I'd do all the cutting there before I start deciding that because somebody's 85 and is in terrible shape, that somebody should pull the plug. I want to tell you all, maybe you've been through this, but I've been through this. I've been through this with my own parent, number one. And I remember going to a hospital and having a doctor. I try to serve internships so I can learn that way. And I got to tell you, people in the medical profession have been really great, even if they don't agree, although I find a lot of people in the healthcare profession are really, their views are changing rapidly, and there's a lot of people who want to see change. And I remember some doctors took me into a room, and they pointed to a guy, and they said, and he had all sorts of technology, you know, attached onto him, and they said, so-and-so is, I mean, he couldn't hear, I hope and pray he couldn't. God knows, I hope he did, seriously. And they said, so-and-so is 67, and he's been smoking all his life, and he's in terrible shape, and he has a 1% chance of living. And then they looked at me, and they said, and this is incredible. You Senator or Paul, whatever they call me, you want to cut expenses? You know, you want to control costs? You know, this is ridiculous. You got to make the decision. And I looked at them and I said, I don't think politicians should make that decision. I don't know who makes that decision. That's the big question.
Hi, I'm particularly interested in issues around children's health, and
yes.
I was wondering if you could talk beyond sort of saying that we should concentrate on prevention, which is obviously very important, to talk about more, perhaps tying in universal access to more comprehensive packages that would not only address children's health needs, which are obviously very important, but income and making sure that we can sort of get beyond only looking at health care as a solution.
First,
My name, Jennifer.
yeah, Jennifer, great question. You know, one stroke of public policy can't change all conditions, all life circumstances, et cetera, et cetera. I don't, as I learned at lunch today, I think need to view healthcare reform within a broader context and precisely the context you're talking about. And that's yet another, if you will, agenda, and a very, very important one. That is to say, there has to be a direct relationship between absolutely miserable jobs or two parents working on different shifts at terrible jobs and hypertension and all of the tension within a family and all of the rest of it. There has to be a connection between, it's fine to say people should have a long-term future orientation if they have a future. There has to be a connection between lack of future right now and completely shut off from opportunities and health care. There has to be a connection between the 10-year-old kids that I meet, that I've met, and the day I stop being angry about this is the day I want to resign. I get so angry when I meet some 10-year-old kid who can't even look me in the face because he or she already knows they're going nowhere. They don't expect to be at the Kennedy School. They don't expect to ever get here. They're already defeated at age 10 and health care. I understand exactly what you're talking about. And frankly, I think that the issues of race and gender and poverty and income inequality in America were not really addressed in any significant way in the campaign, and I worry about what's going to happen. And you know what, you all? I think we're about out of time. This becomes an issue of political power, right? I mean, when all these choices are made, can I just finish up on this? Here's what I'm really worried about, and I don't want to, I'm just thinking out loud. What I worry about with the focus on deficit reduction, have you heard about that? And should. I'm not saying it's an unimportant issue. In fact, I think it is important. I don't put it as the highest public priority. And investment in the economy and all the rest. What I'm worried about is when it comes to the budget cutting, that's going to have to be, along with an economic stimulus plan. I will tell you right now, I'll start again. Politically, there will be no economic stimulus plan in the first one. Now we're talking first 100 days. Healthcare gets going but doesn't get passed. Politically, there'll be no economic stimulus plan if there's not an agreement on deficit reduction. Probably part of the same plan. Probably part of the same omnibus thing, reconciliation bill pulled together. Here's what I worry about. You know how everybody says cut those entitlement programs? Better be careful about who we're cutting. Some people can be very generous with other people suffering. And there's a whole lot of people that are not going to be in that debate. I said to David Elwood earlier, I saw D'Amato come on the floor, and he won on these amendments, albeit I think they took it out in conference committee, but we blessed it in the Senate. He got voice votes on some of them. He come on the floor and things like, you know, it's sort of like what used to happen in New York. Send them, when the poor come to New York, put them on a bus and send them back and pay their ticket and all the rest of it. It's unconstitutional. And you know, I never saw any welfare mothers there. I didn't see them in the ante room. That's outside in the hall. I don't see them there at all. And I know this is an old argument, but this is an even more serious argument. Children's Defense Fund, you know, is a good organization and is there for children, not enough. But children is a respectable way of talking about poverty. People aren't afraid to do that. But when it comes to defending, for example, AFDC mothers, welfare mothers, almost silence. And I want to tell you, I'm real worried about some of the harshness that might take place in social policy when it comes to affecting people on the bottom. That's why I appreciate that question. I know we've run out of time, and I really thank you for being here. Thanks, everybody.